The final chapter in the EMT curriculum is Chapter 40, ALS Assist. After you complete this chapter and the related coursework, you will be able to maximize your skill set in order to lend a greater hand when you assist ALS providers. Additionally, you will demonstrate an understanding of intubation and IV equipment, as well as a fundamental knowledge of basic airway equipment. There are no National EMS Education Standard competencies for this part of the course. You may need to be familiar with the skills normally practiced at the advanced EMT and paramedic levels. These include advanced airway techniques, intravenous therapy, and cardiac monitoring. Establishing and maintaining the patient's airway is the single most important manipulative EMT skill. The airway must be secured immediately or the patient will die. Most conscious patients with an intact gag reflex can maintain their own airway. In managing a conscious patient, you may need only to provide oxygen and monitor the patient closely for any changes. Patients whose consciousness is altered may require an oral or nasal airway and suctioning. The purpose of advanced airway management is to provide better airway protection and improve ventilation by using a tube to create a direct channel into the trachea. The respiratory system consists of all the body structures used for breathing. The upper airway includes the nose, mouth, throat, pharynx, and larynx, or vocal cords. The larynx is typically considered to be the dividing line between upper and lower airways, and the lower airway includes the trachea, bronchi, and lungs. You see a picture here. The mechanical process of breathing occurs through the use of the diaphragm and intercostal muscles. These muscles contract during the active phase of breathing, called inhalation, and during the passive phase of breathing, called exhalation, air flows out of the lungs. The respiratory system delivers oxygen to the body and removes carbon dioxide. This process takes place on two levels. The alveolar capillary exchange, where air is breathed in during inhalation and it travels through the airways to the alveoli, where oxygen-poor blood is circulated through the capillaries around each alveolus. Oxygen in the alveoli crosses over into the bloodstream and carbon dioxide crosses over into the alveoli. And then at the capillary cellular exchange, which occurs through the body's cells, where cells give up carbon dioxide into the capillaries and capillaries give up oxygen to the cells. You see a great example of the two processes here. Each living cell in the body requires a regular supply of oxygen. Some cells, such as those in the heart, brain, and nervous system, need a constant supply to survive and will be damaged or die if the supply is interrupted. Other cells in the body can tolerate short periods without oxygen and still survive. Always assess the airway first in an injured or ill patient. Advanced airway techniques are begun only after proper basic airway management has been completed. The first step in airway management is opening the airway. You should use the head tilt chin lift maneuver in a patient with no suspected spinal injury. If there is a possibility of spinal injury, use the jaw thrust maneuver. Assess the airway and evaluate the need for suctioning to remove foreign bodies, liquid, and blood, and determine if the patient needs an airway adjunct. There are two readily available adjuncts, and those are the oral and nasal airways. Endotracheal intubation. Endotracheal intubation is the insertion of a tube into the trachea to maintain the airway. If it's done through the mouth, it's called orotracheal intubation, and if it's done through the nose, it's called nasotracheal intubation. In either case, the tube passes directly through the larynx between the vocal cords and then into the trachea. It is a very effective method for controlling a patient's airway and has many advantages over other airway management techniques. It is indicated for patients who cannot provide their own airway protection or if they need prolonged artificial ventilation. Before an orotracheal intubation attempt begins, it is vitally important to assemble all the equipment that you will need. The laryngoscope handle and blade, a properly sized ET tube, and a stylet, as well as a 10 milliliter syringe and water-soluble lubricant for the tube. The suction unit, you need a suction unit with rigid and soft-tip catheters, as well as McGill forceps, a stethoscope, a commercial tube securing device, and a secondary confirmation device. You see all of these components here. The laryngoscope's purpose is to sweep the tongue out of the way and align the airway so that the vocal cords can be visualized and the ET tube pass through them. Here is an example of a laryngoscope. The handles in the middle on the right side are what we call Miller or straight blades, and on the left side are what we call Macintosh or curved blades. The size of an ET tube is specified by the measurement of the inside diameter of the tube. The proper size tube for adults range from 7.0 to 8.5 millimeters. For the most efficient use the largest diameter ET tube that will pass easily through the vocal cords. For children, it is best to have a chart or length-based resuscitation tape device to help you with sizing the tube. A standard 15/22 millimeter adapter attaches to any ventilation device, and make sure that it is securely pushed into the tube so that it does not pull off as you ventilate the patient. Note that the centimeter mark for placement of the ET tube by looking at where the tube lines up with the teeth on an intubated patient, and these are marks contained on the tube. In average-sized adults, the tube-to-teeth mark is usually around 22 centimeters. The stylet is a plastic-coated wire, and it may be inserted into the ET tube to add rigidity and shape to the tube during intubation. You bend the tip of the stylet to form a gentle curve for adult intubations. You never insert the stylet past the Murphy's eye because it could puncture or lacerate delicate airway tissue. And before you attempt an intubation, you always confirm that the stylet is not sticking out past the end of the ET tube. You use a 10 milliliter syringe to test for air leaks in the tube before intubation and to fill the cuff when the tube is placed correctly in the trachea. You may also need a suction unit to clear secretions or blood so the vocal cords can be visualized, and the use of a commercial securing device is a very effective means of ensuring the tube does not move once you have it in the correct position. The Selleck maneuver can be used to intubate a patient who has no cough or gag reflex. It helps reduce the chance of regurgitation and aspiration of stomach contents, and it moves the vocal cords into better view during the intubation procedure. You need to follow the steps in Skill Drill 40-1 to perform the Selleck's maneuver. When you perform this maneuver, be sure to correctly identify anatomic landmarks to avoid damaging other structures and inadvertently obstruct the airway. The intubation procedure. Visualize your oral intubation. You may intubate only if authorized to do so by offline or online medical control. You must act quickly, carefully, and efficiently, and be sure to use standard precautions, including the use of gloves, eye protection, and a mask. An intubation attempt should not take more than 30 seconds, and the time limit begins when ventilation stops and the laryngoscope blade is inserted into the patient's mouth. It ends when you begin ventilations again. If your attempt is not successful, stop and withdraw the tube, reoxygenate the patient, and try again according to your local protocols. Intubation is a multiple-person task, especially in a situation involving cardiac arrest and use of an AED. The first EMT applies and uses the AED, and the second and third EMTs perform CPR at a ratio of 30 compressions to 2 ventilations. The fourth EMT prepares and intubates the patient. Follow the steps in Skill Drill 40-2 to perform visualized orotracheal intubation. Now, we will not be performing this as part of the EMT course because in Montana, EMTs without a specialized airway endorsement may not perform advanced airway maneuvers. However, you can perform the steps of assistance. It is essential that you use a secondary method of confirming proper tube placement. EDDs, or esophageal detector devices, are designed to connect directly to the ET tube adapter end once the patient has been intubated. Two commonly used devices are a syringe with a plunger and a bulb syringe. The devices work by attempting to withdraw air from the ET tube. End tidal carbon dioxide detectors and capnography monitors sense the amount of carbon dioxide during the exhalation phase of ventilation. Place the device between the ET tube adapter and the bag mask device and ventilate the patient normally. After a minimum of 6 breaths, look for evidence of carbon dioxide production. Capnography monitors can also be used for secondary confirmation of ET tube placement. During ventilation, the amount of carbon dioxide present is displayed as a number or as a positive waveform on the monitor. These devices do not give a 100% guarantee that the tube is in the correct location. Here you see an example of a LifePak 15 with capnography monitoring. Primary confirmation is the direct visualization of the tube passing through the vocal cords, as well as auscultation of good bilateral breath sounds and seeing the patient's chest rise and fall with each ventilation. Never, ever let go of the ET tube until it has been secured properly. Some complications of intubation include intubation of the right mainstem bronchus. If you place the tube into the trachea too far, it will pass into the right mainstem bronchus. Only the right lung will be ventilated, and you need to deflate the cuff and pull the tube back slightly, reinflating the cuff and reassessing. Esophageal intubation. If the ET tube is inserted without first seeing the vocal cords, it may easily be inserted into the esophagus. The result is rapid inflation of the patient's stomach rather than ventilation of the lungs. You need to auscultate over the epigastrum and over the left and right apices and bases of the lungs. Aggravating spinal injury. Intubation must occur without moving the patient's neck from the neutral inline position. Increased hypoxia. If the procedure cannot be completed within 30 seconds, stop and ventilate the patient with a bag mask device and 100% oxygen for 2 to 3 minutes before you try again. Patient vomiting. You should always check for a gag reflex prior to intubation. You should always have a suction unit ready in case the patient vomits during the intubation procedure. Laryngeospasm. Trying to insert an ET tube through the vocal cords can cause the cords to spasm. Stop the intubation attempt and ventilate the patient with a bag mask device. Trauma. The laryngoscope and the tip of the ET tube can injure the lips, the teeth, the tongue, the gums, and other airway structures. You need to pay careful attention to your technique, and this will minimize trauma risk. Mechanical failure. You may hear or feel air coming from the oropharynx when ventilating the patient, indicating that the cuff may not have enough air in it. Get more air into the cuff or replace the tube. Patients who are intolerant of the ET tube. Before removal of the tube becomes necessary, ensure that a suction unit is nearby and ready. Deflate the cuff and carefully withdraw the tube as the patient exhales. Decrease in heart rate. Monitor the patient's vital signs carefully and continuously. The heart rate may decrease when the airway is stimulated or if the ET tube is misplaced in the esophagus. Reassess and confirm tube placement. Multilumen airways are advanced airways that do not require visualization of the vocal cords for placement. Examples include the Combi tube and Pharyngeotracheal Lumen Airways. They are designed to provide lung ventilation when placed in the trachea or esophagus, thus making them much easier to insert than an ET tube. If the tube happens to go in the trachea, ventilation is provided directly into the lungs as with an ET tube. If it goes into the esophagus, as occurs most often, it can still be provided to the patient. And you can see an example of a Combi tube here. Table 40-1 gives you the benefits and disadvantages of these multilumen airways and again makes a great study reference. Multilumen airways should not be used in the following patients: anyone who is conscious or semi-conscious and has a gag reflex, children younger than 14 years, adults shorter than 5 feet, patients who have ingested a caustic substance, patients who have a known esophageal disease. Removal of the multilumen airway. If the patient will no longer tolerate the airway, it should be removed. Remember, the patient will likely vomit when the airway is removed, so a suction unit must be readily available. When you are ready, simply deflate both balloon cuffs and gently remove the tube. Single lumen airways. The King LT is a single lumen airway that is blindly inserted into the esophagus. It consists of a curved tube with ventilation ports located between two inflatable cuffs. One cuff is designed to seal the esophagus while the other is intended to seal the oropharynx. Openings located between these two cuffs provide ventilation into the lungs. Contraindications include intention for airway management in patients who are taller than 4 feet. High airway pressures may cause air to leak into the stomach or out of the mouth. And if the trachea is intubated, the airway must be removed and another attempt made to place it in the esophagus. LMAs are laryngeal mask airways. The LMA was originally developed for use in the OR, but it has expanded its use into the field. This is an example of a King airway, the single lumen, and here is an LMA. Consists of two parts, the tube and the mask or cuff. After blind insertion, the device molds and seals itself around the laryngeal opening by inflation of the mask, and it comes in 7 sizes and can be used in both children and adults. Gastric or G tubes. Sometimes a patient may require placement of a tube through the nose or mouth that extends into the stomach. Examples include cardiac arrest patients who have an advanced airway in place. A nasal or oral gastric tube relieves gastric distension caused by the introduction of air into the stomach during positive pressure ventilation prior to the advanced airway being used. Gastric distension causes a significant risk of passive regurgitation and aspiration in unconscious patients, and this can result in pneumonia. The gastric tube may also be used by emergency department staff to lavage the stomach in cases of accidental or intentional overdose. After placement, the gastric tube is measured to determine the proper depth of insertion. It's lubricated and then passed through the nostril or mouth and into the stomach. The stomach contents and air can be aspirated or passively allowed to escape through the tube. Proper placement can be confirmed by aspiration of stomach contents with a syringe, listening with a stethoscope as air is introduced into the G tube with a syringe, and a radiograph on arrival at the emergency department. Continuous positive airway pressure, or CPAP. CPAP is used in breathing patients who are alert and able to follow commands and who have reduced function of the alveoli due to congestive heart failure, chronic obstructive pulmonary disease, or asthma. A tight-fitting mask is placed over the mouth and nose and connected to an oxygen source capable of delivering flow rates of at least 50 liters a minute. During the inspiratory phase of respiration, oxygen-rich air is supplied at flow rates high enough to increase airway pressure. During the expiratory phase, the patient exhales against a resistance called positive end expiratory pressure. The combination of pressure results in an increased volume of air in the lungs, alveolar surface available for gas exchange, and oxygen diffusion across the cell membrane. CPAP may be helpful in patients with severe respiratory distress when initial treatments of high-flow oxygen administration are not successful. Make sure that you're monitoring the patient's vital signs. IV therapy. You should develop a routine to follow as you assemble the appropriate equipment. This will help you keep track of your equipment and the steps necessary to complete successful IV administration. Again, in Montana, EMTs at the standard level may not initiate IVs, but there are many times they may assist an ALS provider in getting the equipment ready. So these steps are important. Many medications used by ALS crews are given by the IV route, and a fluid bolus may be indicated for patients who are dehydrated because of vomiting or excessive diarrhea, or patients who have experienced blood loss because of hemorrhage. Gather and prepare all of your equipment before you attempt to start IV administration. By anticipating the needs of your ALS partner, you can help make the IV equipment assembly possible. Table 42 shows the logical sequence of steps for assembling your equipment. In the pre-hospital setting, the choice of IV solution is limited to isotonic crystalloids, normal saline, and lactated ringers. D5W, which is 5% dextrose in water, is often reserved for administering medications. Each IV solution bag is wrapped in a protective sterile plastic bag and is guaranteed to remain sterile until the posted expiration date. Once the protective wrap is torn and removed, the IV solution has a shelf life of 24 hours. The bottom of each IV bag has two ports, an injection port for medication and an access port for connecting an administration set. The more common pre-hospital volumes are 1,000 milliliters and 500 milliliters. An administration set moves fluid from the IV bag into the patient's vascular system. Each administration set has a piercing spike protected by a plastic cover. There are different sizes of administration sets for different situations and patients. Most drip sets have a number visible on the package which indicates the number of drops it takes for a milliliter of fluid to pass through the orifice and into the drip chamber. Drip sets commonly used in the pre-hospital environment come in two primary sizes, micro drip and macro drip. A macro drip is a large drip and a micro drip is a mini drip. You can see those here. The drip set you see here, this is a macro, which is 10 to 15 drops per ml, and over here is a mini. It's a teeny tiny little port, and that takes 60 drops to make a 1 ml. This one only takes 10 to 15. Verify the solution and check for solution clarity as you're preparing your administration set. To spike the bag with the set, follow the steps in Skill Drill 40-3. Saline locks are a way to maintain an active IV site without running fluids through the vein. They're used primarily for patients who do not need fluids but may need rapid medication delivery, and they are attached to the end of an IV catheter and filled with a few milliliters of normal saline to keep the blood from clotting. An IV catheter is a hollow, laser-sharpened needle inside a hollow plastic tube that is inserted into a vein. Once the catheter is properly placed, the needle is removed, leaving the catheter in the vein. You should select the catheter size based on the need for the IV, the condition of the patient's veins, and the location of the IV. Catheters are sized by their diameter and refers to by the gauge. A large diameter catheter corresponds to a smaller gauge. So, for example, a 14 gauge is a large diameter and a 22 is a very small diameter. To start an IV. The first step in starting an IV is to apply a tourniquet proximal to the site where venipuncture is to be performed. When a suitable vein is identified, the area should be cleaned according to local protocol to decrease the chance of introducing potentially infectious materials through the skin. The needle and catheter is then introduced into the vein, the needle withdrawn and disposed of properly, and the IV tubing or lock is placed. You use tape or a commercially available device to secure the catheter, and you always wear gloves during the procedure. Skill Drill 40-4 covers how to start an IV. Tape the area so the catheter and tubing are securely anchored in case of a sudden pull on the line. You should avoid circumferential taping around any extremity because it can act like a constricting band and can decrease circulation. Alternative IV sites and techniques. Intraosseous needles are used for emergency venous access as defined by protocol when other IV access is difficult or impossible. Often, patients are experiencing a life-threatening situation such as cardiac arrest, status epilepticus, or progressive shock. The IO needles are generally inserted in the proximal tibia. An external jugular IV provides venous access through the external jugular veins in the neck. The catheter is inserted midway between the angle of the jaw and the midclavicular line, and these punctures can be difficult because these veins are surrounded by a very tough fibrous sheath that make difficult access. Possible complications of IV therapy. Local reactions include problems like infiltration and phlebitis. Systemic reactions include allergic reactions and a circulatory overload. Infiltration is the escape of fluid into the surrounding tissue when the IV catheter is not in the vein. This can cause a localized area of edema or swelling. Some of the more common reasons are the catheter has passed completely through the vein and out the other side. The IV catheter tip moves out of the vein because of patient movement, or the tape securing the line comes loose. The catheter was inserted at too shallow an angle and has only entered the tissue surrounding the vein, or fluid is escaping from the vein because of a prior venipuncture. Signs and symptoms include edema or swelling at the catheter site, extremely slow IV flow, or a patient complaint of tightness and pain around the site. To correct the infiltration, stop the flow, remove the catheter, and reinsert it at an alternative site. Phlebitis is an inflammation of the vein. It's not usually seen in emergency pre-hospital patients, but it's often associated with fever, tenderness, and red streaking along the course of the associated vein. Some common causes include localized irritation and infection from non-sterile equipment and prolonged IV therapy, as well as irritating IV solutions. Occlusion is the physical blockage of a vein or a catheter. Common causes include the formation of a clot due to blood in the catheter or an insufficient flow rate, the proximity to a valve, or resting of the IV line or crossing the arms, high blood pressure causing blood to back up into the line. Vein irritation is more common with IV medication administration and very uncommon with just fluids. Patients often complain immediately that the IV is bothering them and it may tingle, sting, or itch. A hematoma is an accumulation of blood in the tissues surrounding an IV site. They result from vein perforation or catheter removal. If a hematoma develops when IV catheter insertion is attempted, the procedure should stop. Direct pressure should be applied to help minimize bleeding. Ice application may help, and if a hematoma develops after a successful catheter insertion, evaluate the IV flow and the hematoma. Systemic complications. A systemic complication can evolve from reactions or complications associated with the IV insertion. These usually involve other body systems and can be life-threatening. True anaphylaxis is possible and must be treated aggressively. Allergic reactions can be related to a person's unexpected sensitivity to an IV fluid or medication, and the common signs and symptoms include itching, facial edema and hand edema, bronchospasm, wheezing, shortness of breath, and hives. If an allergic reaction occurs, discontinue the IV fluid and remove the solution, maintain the airway, and monitor the ABCs and vital signs. Air embolus. Healthy adults can tolerate as much as 200 milliliters of air introduced into the circulatory system. Patients who are already ill or injured can be adversely affected if any air is introduced. Proper flushing of an IV line will help eliminate any potential of introducing air into a patient. IV bags are designed to collapse as they empty to help prevent this problem. And be sure to replace empty IV bags with full ones. Treat the patient by placing him or her on the left side with the head down. Circulatory overload. An unmonitored IV bag can lead to circulatory overload. Problems occur when the patient has cardiac, pulmonary, or renal dysfunction. These types of conditions do not allow the patient to tolerate the additional demands associated with increased circulatory volume. The most common cause in the pre-hospital setting is failure to readjust the drip rate after flushing an IV line immediately after insertion. Patient presentation includes shortness of breath, JVD, and increased blood pressure and crackles, as well as acute peripheral edema. To treat a patient with circulatory overload, slow the IV rate to KVO and raise the patient's head to ease respiratory distress. Administer high-flow oxygen and monitor vital signs and shortness of breath. Some patients have anxiety concerning needles or in response to the sight of blood, and they can present with anxiety, diaphoresis, nausea, syncope. Treatment centers on providing supportive care to these patients, like lowering the head of the stretcher and giving them oxygen and monitoring their vital signs. Although uncommon, catheter shear is a potential complication when starting an IV that could have a devastating effect on your patient. It may occur if you attempt to reinsert the needle through the catheter after the needle has been partially withdrawn. Troubleshooting. Several factors can influence the IV flow rate. It is always helpful to perform the following checks after you complete IV administration. Check your set, check the height of the bag, the type of catheter you used, and the tourniquet. Age specifically, things to remember. Pediatric and geriatric populations warrant specific attention. For pediatric patients, the child has smaller veins. A small gauge catheter should be used so that the vessel will be traumatized as little as possible, and generally we're talking about a 22 to 24 gauge catheter. Volume control is important. Use a special type of microdrip set called Volutrol, and this allows you to fill the large drip chamber with a specific amount of fluid and administer only that amount. For geriatric patients, smaller catheters may be preferable unless a rapid fluid replacement is needed. The use of tape can lead to skin damage, so be careful when taping IV catheters and tubing. Also be careful when using macro drips because they can allow a rapid infusion of fluids, which may lead to fluid overload in your geriatric patient. Cardiac monitoring. A 12-lead ECG can help in the early identification of an acute MI. The interpretation of cardiac rhythm may not be an EMT skill, but it is helpful to be able to place electrodes and leads on a patient in preparation for this monitoring. The heart contains a network of specialized tissue called the electrical conduction system that is capable of conducting electrical current through the heart. The flow of electrical current through this network causes contractions of the heart that produce pumping of blood, and the process of electrical conduction occurs. The main function of the electrical conduction system is to create an electrical impulse and transmit it through the heart in an organized manner. The electrical conduction system contains these components. The SA node, which is the sinoatrial node, and it's the heart's main pacemaker. It paces at a rate of 60 to 100 beats a minute. There are 3 intermodal pathways that transmit the pacing impulse from the SA node to the AV or atrioventricular node. The AV node, which transmits the impulse from the atria to the ventricles, and the bundle of His, and then the right and left bundle branches. And you can see an example here of all of these components of the heart's electrical conduction system. The ECG electrodes pick up the electrical activity of the heart, and the ECG machine converts it to a wave. The way the ECG tracing looks depends on where the lead is placed. The ECG Complex. One complex represents one beat of the heart. The complex consists of several waves, the P, the QRS, and the T. A segment is a specific portion of the complex. Here you see an example of this entire complex. You see the P wave, the PR interval. You see the QRS wave and the QT interval, and you see the ST segment and the T wave and the TP. An interval is the distance measured in time occurring between 2 cardiac events. The time between the beginning of the P and the beginning of the QRS is known as the PR interval. ECG paper contains a grid. Each little box represents 1/25th of a second, or 0.04 seconds. Each bigger box is composed of 5 smaller boxes, or 0.20 seconds. 5 big boxes equals a second. Normal sinus rhythm. This is a sinus rhythm in which the SA node acts as the pacemaker. All of the P waves should look the same, and a normal heart rate for most people is between 60 and 100. A rhythm strip with these attributes is showing normal sinus rhythm here. You see the upright normal P wave, the PR interval, and the QRS complex followed by the T wave. Production of the heart's rhythm is a continuous process with no actual period of rest or inactivity. The process works as follows. The baseline is a period where the majority of the cardiac muscle is at rest. The SA node produces an electrical impulse that is conducted through the internodal pathways and into the atrial cardiac muscle cells, resulting in atrial depolarization. The impulse then passes through the AV node. The impulse travels through the bundle of His, right and left bundles, and the fasciculus and the Purkinje system. And as the ventricular muscle cells repolarize, the T wave is formed. If the heart is functioning normally, this process will repeat over and over continuously. And you see these processes occurring through here, up to the beginning of the QRS complex. And then we follow on through the passage through the ventricular structures, the right and left bundle branches, the Purkinje fibers, the bundle of His, and the Purkinje fibers, all the way through the entire cycle. An arrhythmia is an abnormal rhythm of the heart. A meaning absent, and sometimes we use the term dysrhythmia for bad or difficult. The first one we're going to talk about is sinus bradycardia, and you will see it here. This refers to a slow heart rate, usually less than 60. So sinus bradycardia is a rhythm that has consistent upright P waves, a consistent PR interval, and a regular rate of less than 60. Sinus bradycardia typically becomes a problem when the heart rate drops to less than 50. Tachycardia refers to a fast heart rate, usually more than 100. Sinus tachycardia is a rhythm that has consistent P waves, consistent PR intervals, and a regular rate of more than 100. Tachycardia may cause a decrease in cardiac output when the rate becomes so high that the stroke volume is affected. And you can see sinus tachycardia here. Ventricular tachycardia. A basic definition of VTach is simply the presence of 3 or more abnormal ventricular complexes in a row with a rate of more than 100. In general, it is always very regular. Ventricular fibrillation is a rapid, completely disorganized ventricular rhythm with chaotic characteristics. Undulations of varying shapes and sizes with no specific pattern and no discernible P, QRS, or T waves. There is no organized beating of the heart, and the best chance for a patient to survive this rhythm is dependent on rapid defibrillation. Asystole refers to the complete absence of an electrical cardiac activity. It looks like a straight or almost straight line on the ECG strip, and the patient is clinically dead at this point. You may have a 4-lead or a 12-lead ECG system, and newer cardiac monitors include several new features using modern technology. They are compact, light, and portable, and combine defibrillation and monitoring capabilities. A 4-lead ECG uses 4 leads, which are electrodes attached to wires that are attached to the cardiac monitor. These 4 leads are called the limb leads because they are placed on the patient's limbs or close to them. The white lead is on the right shoulder or arm, the black lead is on the left shoulder or arm, the green lead is on the right low abdomen or leg, and the red lead is on the left low abdomen or leg. It does not matter where the leads are placed on the limbs as long as all 4 are at least 10 centimeters from the heart. When using a 12-lead ECG, electrodes are placed as in the 4-lead placement as well as in very specific locations on the chest. Position the V1 and V2 leads on each side of the sternum at the 4th intercostal space. V4 is placed at the 5th intercostal space in the mid-clavicular line. V3 is then placed between 2 and 4. V5 is placed in the anterior axillary line, and V6 in the mid-axillary line at the 5th intercostal space. And you see the proper placement here, and this tells you also the views of the heart you're seeing. It is very important to have direct skin contact when obtaining an ECG. If the skin is sweaty or oily, wipe it clean with a towel. If the patient's hair prevents attachment of the leads, use a razor to remove the excess hair. The importance of obtaining a 12-lead ECG is for early identification of potential myocardial ischemia. And the advantages of 12-lead monitoring are early identification of ischemia as well as accurate identification of cardiac arrhythmias. ST segment elevation myocardial infarction, or STEMI. A STEMI is a specific type of MI in which the ST segment of the cardiac cycle is elevated. A STEMI is treatable by techniques that rapidly restore perfusion to the coronary arteries. Many cardiac monitors available are capable of reading a 12-lead ECG and indicating whether the patient may be having a STEMI. In the goal of achieving the shortest time to reperfusion, potential delays can be minimized. Remember, time is muscle. Working as a team, regardless of certification level, to provide optimal care to your patient is essential. In summary, there may be cases in which an EMT may find it necessary to be familiar with skills normally practiced at the EMT and paramedic level. These skills include advanced airway techniques, IV therapy, and cardiac monitoring. An advanced airway technique is endotracheal intubation, the insertion of a tube into the trachea to maintain the airway. Additional advanced airway care devices include the combi tube, the pharyngeal tracheal Lumen Airway, the King LT, and the laryngeal mask airway. IV therapy is used to replace fluids in a patient with shock or to administer medications. Cardiac monitoring with an ECG is an advanced skill that the EMT may provide in assistance to the AEMT or paramedic. This will probably cause you some significant questions that you may bring to class and talk to your instructor about. Just remember, I will be listing the Montana protocols on the D2L website as well, and realize that EMTs without endorsements or without being an advanced EMT can only assist in these procedures. Thank you, and I hope you've enjoyed your EMT class.